guys, my name is Natasha. I will be presenting a case from my clinical rotation at Orange Park Medical Center, located in Orange Park, Florida. The case is on early mobility in the cardiovascular ICU after heroin withdrawals. So the purpose of my case is to offer information to others. Physical therapy in the ICU is a relatively new thing, so hopefully I can give you guys some tips or some information to make you feel more comfortable if you guys do end up working in the ICU. Also to seek input from others. I'm open to any feedback or opinions or thoughts of anything I could have done any better. Also an opportunity for me to self-reflect, thinking on things that went well or could have gone better. So being in the hospital, I'm able to look at a history and physical that the physician writes when they first see the patient on admission. So these are some points that I got from the physician's notes. On admission, a 29-year-old female presented to the emergency department on the 12th of January for heroin withdrawals. She has a history of daily intravenous and intranasal heroin and cocaine use for the past 5 years. Other than that, a non-significant past medical history. Her vitals and blood gas are as follows. The numbers in red are high and the numbers in blue are low. I'll be using the vitals and blood gas for the smooth safety screen that I'll be talking about in just a little bit. In the emergency department, a diagnosis of sepsis was made, so she was admitted to the ICU. Respiratory failure followed, and she was intubated on the 14th. So in the hospital, some physicians automatically put in a consult for physical therapy, others do not. For her case in particular, we talked about her during rounds, and they decided that she would be a good candidate for physical therapy in the ICU. So she was put on physical therapy caseload. So when patients put on physical therapy caseload and it's intubated, we use the MOVE safety screen to determine whether or not they're a candidate for physical therapy that day. So there's a lot of early mobility guidelines, but there's no gold standard. Most of the ones that I saw all have a respiratory, hemodynamic, and cognitive component, but this is the one that Orange Park Medical Center uses. So we were going to do the initial evaluation on the 16th. However, she had 2 vasopressors at the time, so we weren't able to do the evaluation because the V is for vasopressor, so we had to hold therapy for that day. The next day, she had a femoral catheter put in, and at Orange Park Medical Center, it is absolute contraindication for physical therapy to work with a patient that has a femoral catheter. It's become common practice for physicians to put patients that have a femoral catheter on bed rest to avoid complications such as accidental removal, infection, vascular insufficiency, and clots. However, the research shows that it is safe to work with patients that do have a femoral catheter, as long as the waveform on the monitor is maintained. Despite the research, it is still an absolute contraindication at Orange Park Medical Center to work with a patient that has femoral line. So we weren't able to work with her until the 25th when she got the femoral line removed. So she was on bed rest from the 17th when the femoral line was put in until the 25th when the femoral line was taken out. She was also extubated on the 25th, and we were able to do our initial evaluation on 25th. So before even going in, we have to think of all the equipment that we're using. Because she's ICU status, everything that you disconnected to make sure that you reconnect before you leave. So with her, we're using blood pressure cuff, pulse ox, temperature probe. We've got telemetry up here, nasogastric tube, Foley, supplements oxygen, whether it was the trach vent or a nasal cannula. That's the vent. She's got an IV, a central catheter, and upper extremity restraints. So for the physical therapy evaluation, she presented with a nice laundry list of diagnoses. Just looking at that list and thinking, obviously, some respiratory components, so vitals need to be monitored. The toxic metabolic encephalopathy, you're thinking that she might be confused, and because she was in for a long bed rest, she might be diffused. So the findings for the evaluation, she was on 3 liters of oxygen per the nasal cannula. Her vitals were within normal limits of rest and with activity. She presented with anasarca, and she even noted that it was really hard for her to move because anasarca is a general swelling of the body and extremities. So she was having a hard time moving with all the edema. She was ANO times 3. Her strength was fortified bilaterally for grossly from both lower extremities. Her static sitting was fair plus. Her static standing was poor plus, and her standing dynamic balance was poor. She required mid assist for supine sit, sit to stand transfers, stand pivot transfers from bed to chair. She was able to ambulate 3 feet with mid assist of 2 using a rolling walker. So she is a single mother of 3 children. She is a daughter of 2 very concerned parents who spent a lot of time with her in the ICU. They're a big part of her care. She also has a pregnant sister. She enjoys caring for her children. She's also a bartender and waitress. She lives with her mother, father, and sister in a one-story home with 3 steps to enter, bilateral handrails, and she was independent prior to admission. She was very motivated to participate. She wanted to get out of bed, walk and move. She was unable to see her pregnant sister and her children while she was in the ICU. She got contact precautions, and her family thought it would be best if they just didn't come and see her. Also, her drug addiction is a barrier for her to go home, and she had anxious tendencies. So that was a big barrier in her care. She required a lot of time to be calmed during treatment. So I didn't use any outcome measures. There are no outcome measures that are sensitive to measuring ICU mobility status over time. So instead, we used personal outcomes and goals. The plan of care was for 5 to 7 times a week for 4 weeks. Her goal was to walk. Our goals were for her to be independent with bed mobility and transfers, ambulate 200 feet independently, and have good standing balance without emergency support. Any questions about the evaluation so far?
Were you, because she was on bed rest for so long, were you dealing with any symptoms of delirium or anything?
She didn't have anything like that. Her cognition was pretty good.
When you say femoral line, is that a femoral arterial line?
Yes. Yes. So why do we care so much about early mobility? Early mobility improves functional outcomes upon discharge, decreases ICU and hospital stay, decreases delirium duration, decreases time spent on vent, and increases strength after hospital discharge and in the post-acute setting. Research shows that early mobility is safe and well tolerated at the stage of critical illness, and the most unexpected event was a temporary oxygen desaturation, which was rare and recovered with rest and increase in F5 So early mobility also prevents ICU-acquired weakness. Prolonged bed rest results in disuse and atrophy of skeletal muscle and respiratory muscles. A lot of mechanically vented patients are on prolonged bed rest. So we did the initial evaluation on the 25th. We had to hold therapy the next day because her vitals were too high at rest. We had to hold on the 27th for a stat intubation. At this hospital, whenever there's a unexpected change in medical status, there's a new order required for physical therapy. So whenever there's a new order, we need to do a reevaluation. So next time we saw her would be reevaluation day. The next day, they trialed extubation, and that failed, so she was reintubated. So I was able to do the reevaluation on the 30th. She also received a trach that day. So people who receive trach often have prolonged periods of intubation. With a trach, you're able to hook up the ventilator support, or you're able to hook up oxygen tanks, or you're able to use different types of FiO2, change the FiO2 easily. So people who get trachs have had prolonged intubations. Her vitals were stable at rest and with activity. This time she didn't have the anasarca, so she was able to move better. Her cognition was ANO times 3. Her strength grossly 4 plus at 5 for bilateral lower extremities. Her static sitting balance was fair plus. Her static standing balance was fair, and dynamic standing balance was also fair. Her bed mobility and transfers were contact guard for supine to sit and sit to stand. She was able to ambulate 275 feet with a rollator and contact guard. So able to do much better this time. Plan of care was still 5 to 7 times a week for 4 weeks. Our goals for her would be independent with bed mobility, independent during C stand and ambulate 300 feet. So our first treatment with her, she was using 6 liters of oxygen per her trach mask. Her vitals were within normal limits and stable at rest. Worked on transfers and ambulation. Required min assist for supine to sit and contact guard assist for sit to stand. She had mentioned that the day before she thinks that she did too much, is really fatigued and weak after therapy. At this time she wasn't able to do as much. So she walked 120 feet twice. After the first trial, her heart rate went up to 140, and after the second trial, went up to 150. So this graph is showing her vitals immediately following therapy. We worked with her at about 1 or 2 o'clock, and the chart starts at 3 o'clock. I just want you to see the progressive change in her heart rate over time. It progressively increases until you get to about here. It maxes at 146 at rest. Once it got to there, they put her on the vent. And once the vent was put into place, her heart rate started to go back into normal. This is the same snapshot of time after therapy, but looking at blood pressure and oxygen. So her blood pressure went up until the vent was put into place, and then her blood pressure and oxygen leveled out to normal value. So due to the progressive change in vitals after physical therapy, we had talked about it and discussed the solution. And the solution was to use, she was on the vent at this point, but to increase the vent support while she was walking, so that she was able to do as much as she could functionally with the respiratory support that she needed. So the next treatment, like I said, she was on the mechanical vent. Her FiO2 was 40%, and while we were walking her, FiO2 rose to 60%. Respiratory therapist was present to manage the mechanical vent. She was able to ambulate with a rolling walker contact guard. Not as much as before, only 15 feet the first trial and 60 feet the second trial. The next treatment, we did a similar thing where we increased the amount of FiO2 during gait. Her heart rate rose to 137 with activity, so it was a pretty good increase. Respiratory and nursing were present during the treatment. Then worked on bed mobility transfers and ambulation again. She was still requiring min assist for supine to sit and contact guard for sit to stand. And she was able to use a rollator, standby assist, and ambulate 250 feet, so much more than the time before. So the next treatment, she was no longer on the vent, but she required 4 liters of oxygen via her trach mask. Her vitals were stable at rest, and after activity, her heart rate was 130. We worked on bed mobility, transfers, and ambulation again. She was standby assist for all. Her second trial of ambulation, she was able to ambulate 275. So treatment 5 was also our discharge from therapy. Her vitals, she were normal at rest and during gait. She required 5 liters of oxygen via her trach mask. Her balance was dynamic standing balance was good plus, and she was independent with supine to sit, sit to stand transfers, bed to chair transfers, and she was able to ambulate 500 feet independently. So she met all of her goals. She met independent with bed mobility was met, ambulate 300 feet independently was also met, independent during sit to stand was also met. She was discharged from therapy, however, she was still in the hospital. A lot of time, physical therapy helps to determine if the patient's appropriate for discharge. However, she had this was not the case for this patient. She had to stay in the hospital for other reasons. The main one being her history of IV drug abuse. She was going to stay in the hospital until the 28th of February to complete IV antibiotics. Because the patient has an IV line, it would be irresponsible to send her home for fear of abusing the line. She openly stated that she would not stop doing drugs, so it would be irresponsible to send her home with her. On the 23rd, we were reconsulted for physical therapy. She was on the general floor now at this point, and we were reconsulted for deconditioning. We went and talked to her, and she said that she had any issues with walking in her room. She was still on contact precautions, so she wasn't leaving her room. We told her how to maintain her precautions, but while being able to leave and walk around the floor. Told her that she wasn't able to leave the floor because of her history of drug abuse, but she was able to, that she could go out and walk with nursing if she so desired. She reported no difficulty other than some feeling a little shaky for standing for prolonged periods of time. So we did not pick her up again for therapy. Teamwork makes the dream work. Working with the multidisciplinary team in ICU was really awesome. Since there's no specific guidelines for physical therapy, early mobility, talking about the different problems and barriers that we had, we were able to find a solution to be able to help her reach her potential during therapy while giving her respiratory support that she needed. So that was really cool and it worked really, really well. Things that I would do differently. I would spend more time researching outcome measures. As I mentioned earlier, I said there was no outcome measures that are sensitive to measuring ICU mobility. I was able to find one recently, the PERM Intensive Care Unit Mobility Score. This would have been a really good one for her to use. It assessed a lot of the items that I assessed in the evaluation. So that would have been a really good one that I wish I had known about at the time. ICU diaries helps to decrease anxiety and depression symptoms significantly. I mentioned that anxiety was a big problem for her because she required a lot of time to be calmed. So I would have introduced that if I had known about that at the time. I would have assessed stairs, which is a barrier because she wasn't able to leave the floor. Work scale, that would have been a really good way to measure her rate of perceived exertion that I didn't think of at the time. And I would also have given her home exercise program, something to work on in bed while she wasn't working with therapy. Any questions? Yeah.
You had mentioned that the facility's protocol is not to work with patients who are on the femoral arterial line, but the research that you found suggests and is growing that it's actually safe to do that. Were you able to advocate at all in your time there to improve those protocols?
No, the only reason why that would have been difficult is because one of the intensivists that was in the ICU had a difficulty with a femoral line one time, and there was a scare where a patient bled out, and it's a very big deal. So advocating at the time with that intensivist might have been, it just probably wouldn't have worked out because that event was so recent. Did I answer your question? Yes.
Very cool. I think it's great that you had the opportunity to go into the ICU
Very
and
cool.
close as opposed to just to be fair, but just to be fair type of thing. So how comfortable were you as a student walking into all the bell lines, tubes, etc.? We go through a little bit, but not.
So starting off, my CI was great. He picked up patients that weren't in ICU. So my CI did pretty much only ICU, but he picked up patients that weren't in the ICU for me to start with on the general floor. I got pretty comfortable pretty quick because he was really a good teacher and saying he gave me guidelines to think of when I'm working with lines. I have the lines in front of them. You need to know where your stuff is, and that really helped to give me a process during working in the ICU. So I guess I was pretty comfortable the more I did it.
And the vasopressors on the front end, talking about weren't able to mobilize because of their person was on. Would it just started on the vasopressors, or is it you walk in the room, you sit around vasos, and sorry, we're not playing today.
For the vasopressors, I believe that we had talked with one of the nursing staff that said that they're now introducing vasopressors, so you can
Introduce them.
Yes.
Okay, so there's not.
Yes.
And what did you think about that? About the vasopressor being a hard stop for seeing a patient? Or what did you and your CI discuss about that? What did you guys?
We didn't really talk about much so it being a stop of physical therapy, more so that a lot of intensivists have different opinions about vasopressors. Some say that if they're increasing, no matter how many vasopressors they're on, it's an absolute contraindication. But they could be on a lot of vasopressors, and as long as they're not increasing, they're stable, then you can work with them. So we talked more about that than during the introduction.
So it was a discussion.
Yes, there was a discussion.
Excellent.
one last question. It showed the trending of the vitals.
Right.
What did they attribute the trending of vitals to? Anxiety? Was it overexertion? Was it?
We think that it was more of an overexertion, that it was just like a dosing problem, she just went too much, could have been anxiety, could have been multiple things, but the solution was to increase the illness.